Yeah, good evening and welcome to the webinar of Indian College of Anesthesiologists. Well, the pandemic is somewhat settling, but something in the international arena is opening up. We are all the netizens of the world are threatened by the present conflict going on between Ukraine and Russia. And we hope there will be a peace settlement very soon. With that hope, we will open up the webinar of the day. And this webinar is a fairly new area which we have not discussed till now. Because we are opening up how the environment is suiting us as well as we are abusing the environment with our techniques, our drugs, and our way of living. We have included 3 different areas today, which one is carbon footprint and anesthesia. The other one is eco-friendly operating rooms. And the third part, more interesting to us, how you should effectively and safely dispose our anesthetic waste. These are all dealt by people who are known to these areas very well. And the first speaker is Dr. Shashi Kiran, and second is Zulfiqar, the third one is Manpreet. Anesthesia and carbon footprint. Well, Professor Shashi Kiran, who was in Rohtak, India earlier, now she is one of the faculty members at the East Kent University Hospitals. She is a teaching faculty as well as a clinical anesthesiologist there. And Shashi will be speaking to you all on this particular topic from Kent, UK. Over to you, Shashi, please. Hello. Garg.
Yes, sir.
Is there any problem with the communication?
No, there is no problem. Ma'am is just sharing the slides.
Okay, all right. Okay.
And meanwhile, ma'am is sharing the slides. We'll be having our question and answer session at the end of the 3 talks. You can always type your question in the Q&A section of your online portal from where you have joined it. And we'll be taking all those questions at the end of 3 interesting talks. Over to you, ma'am, Dr. Shashi Kiran. Ma'am, please unmute yourself, ma'am.
Is my screen visible? Slides?
Yeah, screen is visible, but slides are not opened up.
All right. Are they visible now?
No, yes, you are visible, but the screen has not come. Slides has not come.
Now?
No, ma'am.
What is the...
Ma'am, you can stop the sharing, and when you are screen sharing, you can share the entire screen, not the folder file or anything.
Okay.
Yeah.
Is now?
No, ma'am, you have to share again, the same process.
All right. Is that okay now?
Perfect, ma'am.
Yes, perfect.
All right. So thank you, sir, for giving me this opportunity. And thank you, Dr. Garg. So I'll be speaking on anesthesia and carbon footprint. So many greetings from the East Kent University Hospitals, England. It's in Margate, Kent. It has again stopped some issue. All right. So what is carbon footprint? Carbon footprint is total greenhouse gas emissions by an individual, event, organization, or a product. Fluorinating gases, they form 3% of the carbon footprint, and nitrous oxide forms 7%. Modern perioperative healthcare is responsible for about 1,000 kgs of daily medical waste, which amounts to approximately 3 million kilograms of annual greenhouse gas emissions per hospital. So how perioperative medicine results in carbon footprint? This is because of release of sulfur, nitrogen, anesthetic gases, toxic materials, particulate matter, and persistent organic materials from perioperative use. In United States, 8% of the nation's greenhouse emissions is contributed by the perioperative medicine, whereas in United Kingdom alone, anesthesia is responsible for 5% of the carbon footprint, whereas perioperative period is responsible for 25% of total public health sector care emissions. In India and China, healthcare accounts for approximately 5% of the national carbon footprint. However, since the population is quite large in India and China, so actual footprint is much more. So first of all, let's see that how we estimate the carbon footprint. A carbon footprint is estimated by global warming potential, which is rising temperature by greenhouse gases is calculated mathematically. And this is expressed in the terms of carbon dioxide equivalents. The quantitative expression of greenhouse emission estimation is done by life cycle assessment of a particular product. So what is that? That is estimation and addition of entire amount of greenhouse gases emitted in complete life cycle of a particular product, right from its manufacturing to its consumption and disposal. And this is also known as cradle to grave analysis. And which are the various accounted sources? They are Greenhouse Gas Protocol of World Resources Institute, International Organization for Standardization, and Public Available Specification 2050 of British Standard Institution. Now for analysis, either a bottom-up method is used or a top-down. The bottom-up and top-down, these methods are for small amount and large amount of carbon footprint calculation. However, in practical, when it comes to a practical situation, a combination of economic input, output, and life cycle assessment is used. This method is a gold standard technique, and it's robust, accurate, flexible, and reliable. It's very difficult to tell in detail about this method. So I'm just highlighting that we must know that how it is calculated. The calculation of carbon footprint is undertaken under 3 steps. First is selection of greenhouse gas, then is setting up of boundary, and then is collection of data. So after that, the greenhouse gas emissions, they are put in a complex algebraic calculation, and carbon dioxide equivalent is calculated. So how does perioperative care results in carbon footprint? The carbon footprint starts occurring the moment a particular patient leaves home to reach the hospital till the period he reaches back his home after discharge from hospital. And the major sources are production and use of disposables, including single-use surgical devices. I have highlighted in red as anesthetic gases and energy used for HVAC. They are the major sources. And moreover, all operating room waste, which is designated as clinical waste, This results in requirement of its disposal by incineration, thus increasing the carbon footprint. So these various sources are anesthesia related, HVAC system, then combination of anesthesia and surgical material, surgical waste, and miscellaneous. So now let's talk about anesthesia. So again, either we can provide services of anesthesia as local anesthesia, then various drugs are there, disposables are there, then general anesthesia. And this inhalational anesthesia, again, I have encircled. This is responsible for major carbon footprint. Then sedation, analgesia, and relaxation, these components of anesthesia. These slides I have taken from Royal College of Anesthesia. And then we are involved also in maintenance of homeostasis, vascular access, monitoring, cardiovascular and respiratory control, and temperature control during the intraoperative or perioperative period. So all of these, they contribute to carbon footprint. So what's the fate of all these components? The disposable we are using, they are disposed of by combustion. Intravenous drugs, which Dr. Manpreet will be talking in detail, they are metabolized or they are unused residue are combusted. Then packaging of the goods, recycling, inhalation agents, they are exhaled into the atmosphere unchanged. So you will be surprised to know that combustion of 1 kg of polyvinyl chloride material produces 3 kilograms of carbon footprint. And combustion of 1 kg of paper, that produces almost 2.5 kilograms of carbon footprint. This slide depicts the infrared absorption and atmospheric lifetime of the various inhalational anesthetic agents. So as we can see that nitrous oxide has the longest life in the atmosphere, and the global warming potential, however, is less than desflurane, which is nearly 2,500. And these are the carbon dioxide equivalents of different forms of anesthetics. And in this, we can again see that peripheral lung blockade, inhalation anesthesia, mixed TIVA, and the inhaled anesthetics again dominant in release of carbon footprint. This is a very interesting study that the impact of surgery on global climate was studied by McNeil and al. And they studied carbon footprint from 3 hospitals. They were major tertiary care hospitals in Canada, USA, and England. And they found that average of 51 or 50 million carbon dioxide equivalent were released per hospital in a year. So again, desflurane constituted the maximum footprint along with HVAC. So as we know that inhalational anesthetic agents, they are powerful fluorinated greenhouse gases. They remain at atmosphere for nearly 1 to 15 years. And we have already discussed that nitrous oxide has a lifetime of around 110 to 14 years with a heat trapping potential of 300 times more than carbon dioxide. And sevoflurane has 130 times heat trapping potential, and desflurane, again, I have highlighted in red, it is 2,500 nearly more potent. The life cycle greenhouse gas emission of anesthetic drugs was discussed in a study. And what did they do? They did a full cradle to grave approach for the assessment of carbon footprint. And it was found that desflurane accounts for the largest life cycle greenhouse gas impact among the anesthetic drugs. And the impact is much more when a mixture of nitrous oxide and oxygen is used. Although in Western countries, the nitrous oxide is no longer used, but in India, it is widely used. So this is again just to show that the life cycle greenhouse assessment of the inhalational anesthetic agents. Again, Anderson and all, they assess the impact of global climate from general anesthetic potential, general anesthetic gases, and they found that there is significant infrared absorption of the inhalational anesthetic gases. This is again a very interesting study. As we know that hysterectomy is quite commonly performed procedure. So hybrid life cycle assessment was used to quantify environmental emissions from 4 different approaches to hysterectomy: abdominal, vaginal, laparoscopy, and robotic. And it was found that robotic surgery was used with the highest release of carbon footprints, obviously, because it's a long procedure. And so time taken is also more. So proportionately, the anesthetic gases and, a lot of disposables, they are used. So robotic surgery results into the highest carbon footprint. Of course, the choice of volatile anesthetic does matter. So over the years, in hospitals, the use of desflurane is gradually decreasing because of its global warming potential. So it was again estimated that in terms of, if you see the pollution, 1 hour of surgery using sevoflurane is equivalent to driving 5 to 10 kilometers. And 1 hour of nitrous oxide is driving, and 1 hour of desflurane is almost driving 200 to 400 kilometers. Then let's talk about the other things. So this study, Eckelman et al., they compared the life cycle assessment of disposable and reusable laryngeal mask airways, because laryngeal mask airways, they are very commonly used in worldwide. And it was found that reusable laryngeal mask airways were found to have a more favorable environmental profile as compared to disposable LMAs. So right from, they also did a cradle grave analysis from right from manufacturing to the disposable of laryngeal mask airways. And so in this figure, it is being depicted that what is the impact on global warming and pollution, ecotoxicity. So reusable laryngeal mask airway contributes to 7.4 kgs of carbon footprint over its life cycle, whereas the disposable LMS, they contribute to around 11 kgs of carbon dioxide equivalent. And this is equivalent to burning 4 liters of gasoline. Again, this is a very interesting study. So we all know that general anesthesia is associated with more carbon footprint. In recently, carbon footprint from general, regional, and combined regional and general anesthesia for total knee replacement was studied, and what the authors found. So they found that the carbon footprint released from all the techniques was not statistically insignificant. It was comparable. And electricity and HVAC system, they formed a major part. So general anesthesia, spinal anesthesia combines general and spinal anesthesia. So they found that why under spinal anesthesia, the carbon footprint is comparable, whereas it should have technically been lesser than general anesthesia technique. So they attributed that use of oxygen during spinal anesthesia and lot of disposables used, like the spinal trays of plastic, it is disposable, then sheets, needles. So that is why carbon footprint is comparable. And this is the international comparison of carbon footprint resulting from general anesthesia, spinal anesthesia, and general plus spinal anesthesia. So as we can see that in Australia and in China, the carbon footprint is almost comparable, whereas in Europe and US, it is little less because they have better energy conservation measures. So what this article tells us? This article tells that the carbon footprint in carbon dioxide equivalent emissions associated with general anesthesia, spinal and combined general and spinal anesthesia for knee replacement in Australia were similar. The use of single-use equipment, electricity for patient warming, and pharmaceuticals were major sources of footprint across all the anesthetics. Sevoflurane was a significant source of carbon footprint from both general anesthesia and combined anesthesia. Washing and sterilization of reusable items contributed substantially to the carbon footprint because of both spinal and combined anesthesia, and oxygen use was an important contributor to carbon footprint. Although this study was only preliminary study, it was only 30 patients, but it's a food for thought. What are the adverse effects of carbon footprint? Carbon footprint leads on to climate change, as we all know. There has been global increase in temperature worldwide. There has been larger incidence of melting of glaciers and rise in water level exponentially. Ozone layer is being depleted, and there has been incidence of decreased rainfall and increase in the incidence of acid rain. Moreover, there is carcinogenic potential. So how can we reduce the operating room carbon footprint? McGinn et al., they audited operating room recycling, that those things which are recycled, they should be recycled. But if we recycle, does it result in increasing infection rate? So in their study, they found that there is not much difference in the rate of infection if we are using the things which can be reused meticulously. And in another study, it was found that in arthroplasty, a large amount of things were having potential for recycling. Again, the patients, they are reaching the hospital for pre-anesthetic assessments and surgery. It was commented that carbon footprint can be significantly reduced if a surgical outreach clinic is made. Like the patients, they are traveling to tertiary care centers from a far distance, and traveling itself results into larger footprint. So if small centers, they are made for pre-assessments, it can result into the reduction of carbon footprint to a larger extent. This is again a very interesting study that shows that when a major surgery is done, for example, neurosurgery, a lot of things, they are opened, and among them, lot of things and supplies, they remain unused. So it was found in cost-wise. So you can see that so many things were opened at the beginning of surgery, and these things, they were lying unused. So it was estimated that the cost of total surgical supplies was around $8,000, and unused surgical supplies contributed to around $653 cost. Then ASA, what ASA did? ASA, it studied the attitude of anesthesiologists regarding environmental concerns, and along with attitude, knowledge and organization were also studies. So what was done, that a random sampling of 5,200 members of ASA, they were sent an email. So total of 2,000, around 2,100 anesthesiologists responded out of 5,000. And the majority of respondents, they reported that there was insufficient information on how to recycle intraoperatively. They reported sustainability practices such as reprocessing equipment, using pre-filled syringes, and donating unused equipment and supplies. The affirmative response was 48% for reprocessing equipment. It was 56% for using pre-filled syringes and 65% for donating equipment. So when they were asked that, do you have any sustainability programs? A total of 12% respondents indicated that there is lack of leadership to promote sustainability program. So the conclusion from this survey was that there is a lack of hospital-wide organization of sustainability programs. So how can we produce healthcare without harm? The emphasis should be on minimum materials to be used during perioperative period. The reusable linens and towels should be used wherever possible, like we can do in our spinal trays. The recycling and regulated medical waste should be maximized. One must use reprocessed single-use devices wherever possible. The hospital buildings should maximize the use of renewable energy sources available on existing grid system. This is very important. And Dr. Zulfiqar will be talking about the operating room designs. And to improve environmental health, harmful medications, they should be substituted to safer alternatives. Then pharmaceuticals should be safely managed and disposed of. One should try to purchase safer and more sustainable products. Water consumption should be reduced. How we can reduce water consumption? That is by decreasing the use of bottled water in the operating room. One must try to avoid any unnecessary or harmful intervention and misallocation of patients. And any unnecessary ICU admissions, they should be avoided. Use telemedication wherever appropriate. So what, as an anesthetist, what we can do is that for pre-assessment in healthy patients, we can use telemedicine for assessments. And for post-operative, we can, instead of, if patient doesn't have much issues, we can just ask by telephonically that how they are doing. And there should be provision for ambulatory healthcare to reduce unnecessary transport. So these are the WHO recommendations regarding climate friendly hospitals. So in that, what should be done? That hospital energy efficiency should be increased. There should be green building design, which again, Dr. Zulfiqar will be talking about. Then on-site renewable alternative energy generation should be done. The staff must be encouraged walking or cycling, and the use of public transport among the staff. The cars can be pooled, and there should be local grown food facility for the staff and patients. One should try to reduce, reuse, and recycle the inventory. So in a typical day of anesthesia, this much is the carbon footprint which is being generated currently, and NHS aims to decrease the carbon footprint to a quite low level by 2050, and they are saying that by 2050 we will reduce the carbon footprint to 0, and this is the potential of reduction. Now comes the very important thing: what is the role of anesthesiologist in decrease of carbon footprint? So there is a recent study from carbon footprint of general anesthesia in England. And there is a technology known as vapor capture technology. So in this, what is being done is that sevoflurane or inhalation anesthetic agent, it is reprocessed. Like we have given sevoflurane, for example, in a patient administered sevoflurane, that is recaptured and that can be re-administered at least once to the same patient. So this is vaporizer capture technology. And it is shown that if we use vapor vaporizing technology, it can reduce the impact of inhalational anesthetic agents carbon footprint to a very large extent. I'm not endorsing this, but the Baxter company, it has introduced the gas capturing system that is contraflurane. So the inhalational anesthetic agent is captured and recycled into the same patient, at least one. So they claim that there is 69% of reduction in greenhouse gas emissions after implementing the contrafluorine system as compared to baseline. And again, a very important aspect is end-tidal control. So in our OTs, we have this Datex Omida machines, although this is shown D, so it has AI, SYS, and CS2. So here, the inhalational anesthetic agent is adjusted to achieve the desired end-tidal agent. It reduces vapor use to a larger extent. So this is the photograph I clicked yesterday, that as soon as we induce the patient and start the inhalation agent, just tap on the end-tidal control, and it will sample the gas, and then this end-tidal control can help in achieving 1 MAC at a very nominal the sevoflurane, like 2% or 2.4%. So as we can see that in this 1.1 MAC is achieved by using 2% of sevoflurane. And this is very important, especially in elderly patients. So like 80 or 90 years old, where the software will calculate the requirement of MAC according to the patient's age. And so in elderly, we have seen that to achieve 1 MAC, even 0.8% of sevoflurane is sufficient. Then we should reduce the anesthesia equipment use by opening only required equipment. Then again, we have talked much about it, that procure the reusable or reprocess the equipment. And this is again very important. The stock inventory should be adjusted to a minimum required levels so as to reduce the expired items. And also it is very important to segregate carefully according to the type of waste. Again, one thing that it is very important to avoid putting all the things into a single bin, which makes the recycling programs, especially the use of plastics, paper, cardboards, etc., extremely difficult. So, and seriously consider use of reusable linen. Electronics, they constitute a very important component of operating room. One must avoid the use of electronics which have no proven benefit in a particular case. And monitoring wise also, we can reduce the carbon footprint if we use optimum monitoring things in a particular patient. Then one must use a qualified electronics recycling vendor for disposal of old equipment while negotiating for upgradation of equipments in operating room. The suppliers and distributors, they should be impressed upon to take back old equipment for refurbishment, reuse, and possible donations. Anesthesiologists, they should take a leadership program. They should establish a sustainability committee at their workplace so as to make the things environmental friendly, because we are all the time in the operating room. And we should be proactive in educating staff members regarding the cost-benefit ratio of various environmental projects. This can lead on to remarkable reduction in the carbon footprint. And this will also result in cost savings. We should re-examine our attitudes towards clinical practice, towards development of a safer environment. We should reduce inhaled anesthetic waste, intravenous unused medications, and old discarded anesthesia equipment. Of course, the safety should not be compromised. And we should try to appropriately segregate solid waste. Most importantly, what we can do is we should join a sustainability committee which can cater to issues related in reduction of carbon footprint. So what is sustainable anesthesia? So this is which results into economic benefit and clinical needs are met and are along with environmental success. So one must use wisely, that day surgery should be considered by default for most surgical small procedures to reduce carbon footprint. And patients, they do not need to come into the hospitals on the day before surgery if they have had appropriate preoperative assessment and preparation. Most of the patients do not need routine preoperative tests before minor or intermediate surgery. I know it's different in India and West, because in India, most of the patients, they are coming for their surgery for the first time. It's their first, entry into the hospital. But for healthy subjects, we can avoid. Of course, we can make institutional policy regarding this. For many patients, the chances of harm can be reduced if they are given public knowledge about improving their fitness, stopping smoking, and reducing alcohol intake. And in some cases, of course, weight reduction should also be encouraged for months before their surgery. The government should also be amenable to suggestions from healthcare providers regarding safe and effective patient-centered health services. There's a large scope for future research in this area with respect to mitigation of climatic changes and improvement in public health. So, to conclude, perioperative healthcare generation results into considerable amount of hospital waste, resulting into generation of greenhouse gas. The resultant carbon footprint has potentially devastating impact on environmental and human health. Providing a quality perioperative care to the patient without generation of significant carbon footprint is one of the increasingly challenging concerns. Of course, carbon footprint cannot be reduced by miracle or magic, though we can reduce to a greater extent. And these are the various administrative components. So I encourage that everyone should go through this Royal College of Anesthesia for provision of safer and greener anesthesia. And thank you very much for your kind attention.
Thank you so much, ma'am, for this interesting talk where you have given us various source of interventions where we can take care of our environment. And really, it is amazing one to see that, in fact, we are responsible for increasing the carbon footprint, and we have many options available. So we are really enlightened. Question answer we'll take at the last. And I think in your sequence, I will request Dr. Manpreet Singh to come first, because before we go to the eco-friendly operating rooms, let's see that, as you mentioned in one of your slides, that drugs also has an impact on the carbon footprint. So I will request Dr. Manpreet Singh to take us through for the safe disposal or of the various anesthetic drugs. We load fentanyl, atropine, mephedrine, propofol, and then who disposes and what way, we do not know. And I am sure that Dr. Manpreet Singh is the right person to speak on this topic. He is Professor, Department of Anesthesia at Government Medical College and Hospital. He has many laurels to it. He is a wonderful clinician, academician, researcher, social human being, and he has many laurels for various workshops, publications, chapters. He is editor of books also, and he is on the sitting capacity of various organizations and delivering a good amount of work for teaching and training purpose. He is also General Secretary of Academic College of Emergency Medicine in India and doing a great work in propagating the emergency medicine across. He is also General Secretary of National Association of Critical Care Medicine. Over to you, Professor Manpreet Singh.
Thank you, Dr. Rakesh, for an elaborate biodata of me. And I'm going to share my screen first, because that takes some technical part in that. Just hold on. Is it visible now?
It's coming up, sir.
Okay. Now it's visible?
Yeah. Full screen. Yeah, perfect, sir.
Okay. The topic, when this topic was given to me, I'm first of all thankful to all the organizers of Indian College of Anesthesiologists and Dr. Rakesh. The topic was something different when it was given to me. And the beauty of this topic was that there is a very less literature available on the internet. Very less literature. I searched a lot for this topic. It is safe disposal of leftover anesthetic drugs. But I will holistically cover this topic, not only the disposal part only, because disposal, you all know that prevention is better than cure. So let me talk holistically right from base to the sky. I am Manpreet Singh from Department of Anesthesia at Chandigarh, and it is very important to know that optimum utilization of drugs should be there with the proper protocols. There should be economy of the drugs always to be taken care of because there is a financial burden on that. Then safety of disposal of leftover drugs is another issue. Then prevention of the wastage of drugs is another part. These all whole 4 parts, they comprise of this topic completely if I see in depth of this topic. We have common anesthetic drugs which we use in our day-to-day life. You all can see on the slide. These are the common drugs which we use. And why? Let me see why this topic has so much of depth. Because optimum utilization with proper protocols is the first part of this topic. Which are the drugs to be used? What are the routes of the administration, doses and desired effects, optimal storage of the drugs? These all have an impact on the disposal and creating the environmental effects on that. Then there is a financial burden and economy that has a special part which leads to when we dispose the drugs, how does it affect the hospital economy? How does it affect the anesthesia financial burden? It increases, or the cost of anesthesia which increases nowadays. How much drug is to be used? Minimum drugs to be used without compromising the quality of anesthesia is another challenge. Then we have safety of disposal of leftover drugs. This is the routine OT. If I give you a scenario, 3 cases were scheduled. 33 ml of propofol were used in all the 3 cases. What about rest 7 ml in second vial? So what should I do to that vial? What should I do now afterwards? Then prevention and wastage of the drugs, it decrease the wastage of drugs to the minimum. How can I do that? And how it should affect the quality and how it compromises the quality of the patient care. The basic principles to be kept in mind is that all of these 4 things, that is optimal storage and utilization, cost effectiveness, prevention of wastage, and then rational disposal. These all, the main aim is there should be safety of the patient and the quality is the paramount. You can't decrease the quality to make the patients, to decrease the cost. So there are a hierarchy of priorities which have been given in the literature. First of all, we should take care of the patients, then healthcare professionals, and then the public. Important is you must follow prevention is better than cure. I told you. The storage part has one. First part is the storage part. If you see, if your drugs are properly stored, then the disposal can become very easy later on. The utilization is perfect. That is important activity in the medicines supply chain management has to be done. Then objectives of the anesthesia drug storage practice guidelines are there. The objectives are to ensure the reliable supplies of good quality appropriate drugs are stored in appropriate facilities and managed by the well-trained personnel and are always available as needed for the patients. Then there are good storage practices which persist in ensuring the quality, safety, and identity of the pharmaceutical products. Then improper storage of medicines, this can lead to the misplacement of stock and stock expiry, stock outs and overstockings. And then this leads to the negative health outcomes such as interruption of the crucial treatment and resistance. Like biggest example is antimicrobials which you use. So what is required for optimal storage? You should have adequate storage areas. Those are the clean, dry, and maintained within the acceptable temperature limits. all personnel should receive the proper training. Whosoever is dealing with the storage of the drugs, those persons should be well trained how I have to store these type of drugs and where. Injections should have the separate part, then the tablet should have the separate part, and how I can do with these drugs and what is the temperature where I should do that. Storage off the floor is important because it may cause breakage during the cleaning and inspection. Then rejected material and pharmaceutical products must be identified. It should be controlled one. And broken or damaged items should be withdrawn from the usable stocks and separated from that. And then placement and transportation from store through the OT to the store. These are, again, you have to take care of these things because drug ampoules may break during that. And how to dispose those drugs, where it should fall. Suppose the drug ampoule is broken, then how it can cause the bad effect to the environment. So arrange products in the storage area to facilitate the first to expire and first out. This is called as FIFO and FIFO, FEFO and FIFO. So you have to put those in the stocks which are going to expire. You should be in front. Then what is further required is ventilation and cooling to the drugs. Then it should be directly protected from the direct sunlight. It should not be under the sunlight. In most of the operation theaters, these are off sunlights, but sometimes it has a near sun room near to the sunlight where it comes. Then on the top floors, then it may cause a harm to the drugs. The security and safety, then store the roof for the leaks. You have to check for the leaks are there or not. That will hamper the drugs later on. And then stock the products should be stacked correctly. And what is the important thing is you have to update backup files for computerized inventory control records also. Maintain the records whatever are there inside the store, and then a backup in the store. Computerized backup should always be there with that. Then there should be check for the signs of rodents, insects and roof leaks. These are the small things you have to take care of to prevent your drugs. Then AC ducts and fix the responsibility of the store. You have to have some fix the responsibility, give the responsibility to the person. It should be accountable whatever goes wrong into the record keeping. Storage temperatures of the anesthesia drugs has always been issue. So what happens is room temperature is comfortable. The comfortable room temperature is inside is 20 to 25 degrees centigrade, and routine drugs have their own storage temperature. There is a concept of the drugs temperature. If I see that there is in literature, South African Society of Anesthesia, they do not recommend any storage refrigerated drugs or something like that. The Royal College of Anesthetists and Association of Anesthetists of Great Britain and Ireland have set out their own guidelines how to store that. And the Australian and New Zealand College of Anesthetists, they gave their temperatures, how the drugs, which drug should be stored at what temperature. If you see the list of common drugs, succinylcholine is commonly used in Indian setups or developing setups. It is manufacturer says that it should be stored at 2 to 8 degrees centigrade. And the important thing is in the published literature is the room temperature for 4 to 8 months, it has a shelf life if it is kept at the room temperature. And then rocuronium has 2 to 8 degrees, and storage at room temperature is just 14 days, which leads to unfavorable intubating conditions. This means after it is 14 days, the intubating conditions are not that which is expected. So you have to be very careful if it is not stored at 2 to 8 degrees. Then atracurium, 2 to 8 degrees, it is commonly used in the environment, in the operation theaters. We always use the storage at room temperature is only for 2 weeks. Otherwise, it does not cause any clinical significant drug degradation. So there is a hampering of degradation process of atracurium whenever you use outside this temperature if the drug is put in the store for a longer time. Cis atracurium has 2 to 8 degrees at room temperature, it can be shelf life can be for the 3 to 8 months. Phenylephrine, it has basically, the manufacturer says it should be at or below 25 degrees. And then how the drug has to be constituted or reconstituted, that also matters. Which fluid you are using, 0.9% sodium chloride. If it is used, then how many days it can be a stable drug for the for use. Later on, it can be discarded. But how to be discarded? When to be discarded? Then phenylephrine, I'll tell you why it is important. Because phenylephrine has its own role. Then heparin has below 25 degrees centigrade, but there is no recommendation at how much is the shelf life for this below 25. Oxytocin 228, then ergometrin 228. These all have been a specific temperatures which can be used for 7 days, or you can use ergometrin can be used for the month also at the room temperature. Now, storage temperatures which are given are propofol should be stored between 4 to 25 degrees. Thiopentone is refrigerated at 2 to 8 degrees maximum for 24 hours. So you have to consume in 24 hours. Store in room temperature is maximum for 6 hours. So at room temperature, it will be used as 6 hours only. Etamine at normal room temperature, etomidate is 20 to 25 degrees centigrade. Midazolam not more than 24 hours if stored under refrigeration at the temperature between 2 to 8 degrees centigrade. Neostigmine is stored in ambient temperature, glycopyrrolate at 4 degrees centigrade. For up to 90 days, you can use that. Then local anesthetics 20 to 25. These are all mostly used at a 20 to 25 degrees, and analgesics at the room temperature. The other thing is that manufacturer says that when the adequate temperature storage conditions are not given for any pharmaceutical product, then it needs to maintain the efficacy and safety is not until the expiration date. So they are not giving the guarantee if you're not keeping the drugs at the correct temperatures which they are advocating. The degradation of drugs are caused by chemical reactions due to what happens to these drugs after this temperature. This will be degraded by the chemical reactions like hydrolysis due to water exposure, oxidation due to oxygen exposure. This propofol gets oxidized as soon as it comes into the oxygen exposure. Then physical reactions like alteration of the particle size, disintegration of suspension, absorption of the water. Then temperature is recognized as the most important factor driving these reactions. So we have to maintain the temperature altogether. Another part is not only storage of drugs have recommended temperatures, that is a risk factor for accelerated degradation. The risk of failure and unpredictable therapeutic response is also there. But the storage in temperatures below the manufacturing, suppose a drug is to be kept at 20 degrees or 25 degrees, but if you store at 2 degrees, that may lead to the denaturing of the proteinaceous products. This poses a challenge in the emergency situations when you use these type of drugs. So it has a dual sword. You have to keep according to the manufacturer's recommendations. Why I am talking of so much about the temperature? Because there is a financial concern and wastage of the anesthetic agents. Then relatively later on, you have to dispose these drugs unnecessarily, and then it causes whatever madam has told about carbon footprints and all those things, environmental effects. These all contribute to those concerns. But the most important thing is financial concerns and wastage of the anesthetic agents. Let me show you this picture also. There is a tremendous development in the field of the anesthetic drugs and equipments. What is the important thing is, by decreasing the wastage of the drugs and materials without compromising the quality of the patient care, this financial burden can be lessened. But we do not know how much inadvertently or with ignorance we cause the anesthetic, increase the anesthetic cost, and because of certain factors. Wasted drugs like propofol, these cause environmental contamination with possible harmful ecological effects. Then we have the maximum amount of drug wasted by the volume. Most of the times in the various studies it has been found is propofol. Then it is followed by thiopentone, mefentermine, and vecuronium. Then if you see the average wastage is rupees 750 to 2,500 per day due to anesthetic gases. And this is huge. if you collectively calculate the amount of the cost for each and every hospital, if you see that amounts to be a large one. Propofol is most common drug that is wasted, and the incidence in various literatures it is 30 to 53%. And the studies say that it is always possible to decrease the wastage of propofol by 20% at all times. Then large vials like 50, example is the 50 ml vials, if you are using for infusion, initially for the induction, which were coming before, then rest of the drug used to be wasted when these type of large vials were used. So we used to, then it was shifted to 20 ml of vials, which came into being. Then the effective communication with surgeon and technical staff, it has a peculiar effect with the financial concerns. The effect of wastage, if you see, propofol does not get degraded in nature and has possible harmful ecological effects, keeping in view that it has an advantage of early recovery, then reduced post-op nausea, vomiting. So it comes later on, it comes nearly to equal that whatever you lose, you gain something from one drug. The vacuronium contributes 30 to 36% of the financial loss most of the times. The remedy which they decided is, most of the studies, that judicious use of neuromuscular blockers, assessing the degree of blockade and loading only the required amount these are essential to limit the wastage. Another possible option is procure the 4 milligram of the vials. Volume of thiopentone is wasted higher than any drug, that is 2 to 4%. And then knowledge about the inexpensive, what was the reason behind the wastage of thiopentone? Most of the studies, 2-3 studies are there only, which has told that ultimately knowledge about the inexpensive nature of the thiopentone sodium and easy availability in the hospital supply, that has explained the unexpected increased wastage of anesthesia. So people become little careless when it comes to be cheaper drugs in their hand. So dexmedetomidine contributes next higher thing. It has a high unit price, but it has a faster recovery, opioid requirement decreases. So overall, it comes to equivalence in that use of the dexmedetomidine. Then another is the atropine and mephentermine. Let me tell you, 3.6 to 6.1% of all the financial loss, it has been given with these drugs. The reason is, in most of the hospital practices and in the traditional conventional practices, the people use anesthesiologists, they load the these atropine and mephentermine in their syringes, and they keep there always, so that there is a whenever there is a bradycardia, it can be taken care of immediately whenever there is the person is alone, or sometimes the situation does not arise like that. So what happens is, if it is a single anesthesiologist, then it is a justified thing. The secondly, what is the relevant thing which has been given is that if always you can put the ampule near to the anesthesia workstation, and whenever it is required, you can immediately break and then you can use it. The crux is that we should not waste daily so many of the atropine ampules, so that in crisis it comes to bradycardia, then I'll use that. Then adequate fluid management, assessing and limiting the level of neuraxial blockade would be helpful to decrease the need for mephentermine and ephedrine. Then pre-filled syringes have a deep impact, that they can also reduce the wastage and allow the cost minimization. Adrenaline is also similarly common practice at some places, and nowadays other places it has changed, the practices has been changed, so uses has been decreased, and the utilization, whether it is utilized or not, but the ampules are not broken nowadays. Opioids have another wastage cost. 5 to 7% of the total cost is used whenever it is used in the injectors, fentanyl ampules and all those things. All the opioids, I'll take details in about the opioids. Then wastage of neostigmine, lignocaine. Lignocaine is still again one same thing, that at some institutions what happens is, lignocaine is filled into the syringes, put it on the trolleys, but if there is any arrhythmias, then I'll use that. But the remedy is, ultimately at the end of the day, those lignocaine which has been taken off, they have been thrown away. So how to throw, what is the financial burden of lignocaine? That is also important. So then other is the routine preparation of scoline for all adult cases. anticipating that endotracheal intubation or airway complications such as laryngospasm may occur. This is also important thing, that we have to see our practices, how much drug succinylcholine is used, and whether it is just made every day and it is used, how many times it is used. But the important thing is anesthesia. You remember this, anesthetic cost accounts for only 5 to 6% of the overall perioperative expenditure of the surgical patient. But 40% of the total hospital expenditure comes from operation theaters. So that is a huge thing. Although the anesthetic drug cost constitutes a smaller fraction of the total hospital expenditure, but they are constantly, this is the one line to be underlined, the anesthesiologists are constantly under scrutiny by the hospital financial departments and administrators. The limited availability of resources to meet the healthcare needs and significance of the developing methods to decrease the healthcare expenditure are stressed on. Anesthetic drug wastage varies with anesthesia provider and the institution protocols. Other reasons, if I say, then anesthesiologists may not be, the one reason various studies have told that anesthesiologists may not be aware of the specific cost of the particular anesthetic technique or the procedure. So this is a common thing. We are not aware of most of the times how much is the cost of the ampule, how much is this drug for, and how much is the overall expenditure I have done. Our junior residents and anesthesia technical staffs should be made aware of the cost of the drugs and importance of the waste, that is waste reduction strategies. Application of the interventional education program should be focused on waste reduction, and various CMEs and standard SOPs can be made in each and every operation theater or hospital protocols. Better understanding of the pharmacokinetics is another issue, which if it decreases the wastage and cost increase can be decreased with this, where if you know the pharmacokinetics of each and every drug. Then placing a price list near the drug tray. Some studies they have found that when they put the price list near the drug tray, people are more vigilant on seeing that. So the wastage factor reduces. Keeping an emergency drug tray attached to the workstation also reduces this wastage. Assess the drug requirement for the particular procedure before starting. Talk to the surgeons, how much is the duration. We daily talk, but we do not pay attention towards our formulations of the drugs. The seminars and symposium on anesthesia drug wastage can decrease the cost reduction. The choice of the anesthesia drugs and techniques also affected 50% of the intraoperative anesthesia cost. Anesthesiologist's role in cost saving spread beyond the operation suite also in decreasing the post-op complications. Like in the cases of epidural catheters, they have significantly reduced the overall hospital stay of the patient because of analgesia. So these are the examples where anesthesiologists can pitch in, and they can decrease with different techniques, and they can make the things more cost effectively. Then involvement of the senior faculties also has given a special attention in monitoring the practice of wastage of the reduction in the protocols, and audits also have that. Then choosing the appropriate drugs and techniques. Use of low fresh gas flow rates. It has been seen that low fresh gas flow rates, if you use that, then the wastage of the drugs is less. Then there are controversies about different anesthetic techniques, spinal versus GA for particular surgery, then patient safety, side effects, or two other different anesthesia techniques, high flow and the low flow anesthesias, and with one agent or with TIVA. These all are still into the studies, and there are some formulae which are given for the cost of calculation of the cost. I am not going to detail, but it is there given in the literature how the cost of the wasted drug can be calculated. This is one aspect which I am telling you. Other agents, if I talk of COVID-19 now, second wave, the oxygen was a most precious thing which came into being, and we are using oxygen since we have started the anesthesia. And this has a specific role, but the actual cost of the oxygen came into being into the minds of the anesthesiologists when in the second wave of the COVID, when there was a scarcity of the oxygen. So low flow anesthesia can be used, then nebulization in operation theater through electrical nebulizers instead of oxygen nebulizations. Then there should be no wastage, leakage in the machines, measured through monitors, air use with the oxygen. This all, or there is a judicious use of the oxygen face mask. Which face mask, which venturi to be used in the pre-operatively, when you give the fiber optic, awake fiber optic intubations, then you use, sometimes you use these nebulizations before that. So you have to judiciously use the oxygen at that time. And as the inhalational agents are supplied in liquid formulations, but used as vapors, and the amount of liquid can also be calculated. How much I have put in, how much the MAC, according to the MAC I am giving to the patient, how much is the requirement, and how much is the leftover. Both fresh flow, gas flow, and concentration are important. The cost of the soda lime calculation has also to be done during that. And hemodynamic parameters and surrogate signs can be used to monitor the depth of anesthesia by spectral index. This also in one study has reduced the overall cost of the agents. Then provided the flows are constant, non-soluble agents such as desflurane and sevoflurane, these are costlier than isoflurane. This has been found in the 2 of the studies. And this difference is due to sevoflurane being 2.5 times costlier than isoflurane. Then PIVA, on the contrary, has been universally found to be the costliest technique. It has been seen in the literature, but use of low flow anesthesia with isoflurane significantly decreased the cost of anesthesia as compared to use of high flow technique. If you see the cost comparison, a desflurane versus propofol based general anesthesia technique by Michael Rosenberg, they have said that if the resources are there in the future and there will be limited, it is in everyone's best interest to use them wisely. Always use the wisely, because wisely. And you know, as Dr. Shashi has already told you, desflurane has lost some interest in the people with the compliance of the anesthesiologist due to cost and due to the ecological effects which it has caused. Then propofol wastage in anesthesia, you see that whatever propofol you take it out and then you throw it out later on, it is very toxic to the aquatic and organisms. So it may cause long-term adverse effects in the aquatic environment. So how much it is affecting, I don't know, but literature says in the long term, it causes the harmful effects on that. Though then lidocaine, it has a environmental risk is very insignificant, but it also causes low toxicity to the aquatic organisms. Then succinylcholine has not much bad effects which has been given in the literature. Bupivacaine is harmful to the aquatic organisms and may cause long-term adverse effects in the aquatic environment, which is what literature says to us, that when we discard these drugs, then these drugs may cause the bad or harmful effects on there. Similarly, there is ephedrine also has some acute and prolonged toxicity to the fish, and it can be used. These are all environmental effects which already madam has told about carbon footprints, but these are the silent wastages which we occur into the drugs disposal in the operation theaters. Caution is always for the certain drugs disposal. There is a Drug Enforcement Administration also, which is called a DEA. They have given certain controlled substance for schedule 1 to 5 pharmaceuticals. They have said that certain drugs like ketamine, diazepam, codeine, then are opioids. These are all to be disposed on larger scale in the witness incineration. So it is disposed in the witness incineration because it has more of the harmful effects like addiction, or the leftover opioids can be malutilized by the drug addicts. It can be utilized by the other people which are very closely related to this profession. And also these opioids may cause the harmful effects in the environment. So best disposal option is to find a drug take back location. Suppose the drug is expired. So what to do with that? You have to look for the take back option from the drug manufacturers. And this can be done through hospital, this can be retail, or they can do later on how much they can give the looking after the efficacy and how to maintain that temperature. All those things the manufacturers can take care of. This is the best for each and every hospital. Check the FDA's flush list. this is another thing which I came to know about, is this flush list has a 15 types of different drugs, including opioids and other things, that has to be flushed into the toilet, because this is one thing which can cause more harm rather than keeping it here and there in the hospital, either different premises. So that the misuse and abuse potential is more of these drugs, and this can result in death from one dose if inappropriately taken. The drugs that this flush list is, if the case, if the drugs are like having buprenorphine, or there can be fentanyl word written on that, hydrocodone, these are all opioids ones. Then we have the meperidine, methadone, morphine, these are all opioids. And tapentadol, which is nowadays in the for the pain, and these are to be taken care of before disposing, because these are to be flushed in the toilet only. And drugs that do not contain the opioids and they come into this list are the sodium oxybates and the diazepam rectal gels, and then there are certain transdermal system of methylphenidate. So this is what literature says, that these 15 things are to be taken care of. Then there are risks associated with the environmental release of pharmaceuticals on the US FDA and flush list. And they have said that using similar conservative assumptions of human health risk, all 15 flush list drug list present negligible risk through the ingestion of water and fish. That's why you can use it. This flush list can be used as what they have said, and it is not harmful to the water and fish. In the inhalational gases, as Madam has already told about the carbon effect, and I must say that all the inhalational agents, they cause climate pollutants also, and they create the pollution in that because of these potent greenhouse effect in the gases. So all desfluranes, halogens, all these things, inhalational agents, these are to be taken care of, that it should be utilized appropriately to the point, and this decreases further the greenhouse effect. So lessons learned are that you should, from this chapter, are that we should be not only taking care of the disposal, we should be taking care of how to handle the drugs, optimal storage and utilization of the anesthetic drugs. Then what are the financial concerns about these drugs are very important, and how hospital financial burden is reduced if you use judiciously, and it can give further better patient care. And prevention of wastage of anesthetic drugs reduces the cost of treatment and thus hospital expenses. Then rational disposal of drugs according to the ecosystem, keeping view of the ecosystem and DEA controlled substances with the flush list and all those things. You should not waste, put the drugs at the wrong places. This is to be taken care of. And then safety is the paramount importance for the patient care. Timely access to the drugs, then raising the awareness of the risk and uses of drugs to the students, to the technical staff, to all the anesthesiologists, development of the vigilant, supportive, caring culture, and provide clear guidance and messages, logical approach to the storage of drugs, then audit of the drugs utilized and unutilized versus cost must be done on monthly or 3-monthly basis, because cost containment and cost effective use of resources has become a priority within the healthcare. The use of drugs should not and cannot be restricted to decrease cost and hence compromise patient care. The simple measures suggested would be helpful in decreasing drug wastage and the cost of the anesthetic without altering the quality of patient care with the proper disposal. Thank you so much.
Thank you so much, sir, for the interesting session. So we will take up the question after the third session, sir. So I will request.
Thank you.
I will request now to the another interesting session about the eco-friendly environment is the eco-friendly operating rooms. So I think this is again one of the important sessions, because whatever two things Professor Shashi, Kiran and Professor Manpreet Singh has said to us, let's see how this can be incorporated into the whole assembly of operating rooms. And for this, we have our speaker, Dr. Zulfiqar Ali, who is additional professor in the division of neuroanesthesia and critical care at SKIMS SORA. He is a great academician and researcher and a wonderful human being. He is looking after the neurosciences ICU at SKIMS Srinagar itself. He's a course coordinator for DNB neuroanesthesia and critical care, and he's the apt person for it because he is involved in so many of the technical and administrative aspect of uh, making of ICUs and the operating rooms. So I think he's the right person. Has many laurels, many publications to his credit. He has developed various guidelines for the Indian scenario, and he's a awardee in multiple forum for multiple good work that he is doing. So over to you, Dr. Zulfiqar, for another interesting session of eco-friendly operating rooms. Over to you, sir.
Thank you, Dr. Rakesh. Thanks. I'm humbled by your introduction. Before starting, I would like to thank the Indian College of Anesthesiologists, Dr. Radhakrishnan and Dr. Rakesh in particular, for giving me a chance to be a part of this academic event. I'll be briefly discussing the eco-friendly operating rooms and the steps that we need to take once we are working in an operating room, as how to make it more safer for ourselves and for our environment. Are my slides visible?
Yeah, they're visible.
Yeah, thank you. Unfortunately, we do not have a lot of data in this regard from India. Most of the data is from the Western countries, United States and United Kingdom. And what has transpired from United States is, unfortunately, there are around 8% of the greenhouse gas emissions that occur, that come from the health sector. And hospitals are one of the largest contributors to the environmental contamination. Physicians who are involved in delivering anesthesia, they have to take up a leadership role, because most of the times it's we who works in the operating rooms. And if we do not take timely measures, time is approaching when in the near future, government is going to come out, governments across the world, they will come out with guidelines that will definitely affect our practice. These are some of the steps. I'll be summarizing all these steps briefly as how we can make our operating rooms more greener, more eco-friendly. So first of all, we have to have an idea. We have to choose safer anesthesia equipment. And then we have to have a brief understanding of the environmental impact of inhalational anesthetics, as Dr. Shashi pointed out. And then third is how, once we have a better understanding, it will help us to judiciously use the anesthetic gases so as to reduce the environmental contamination or environmental pollution. Many a times we feel that if we use intravenous anesthetics, they may be less harmful. So we'll see whether this really is true. And briefly, it has been already covered extensively by Dr. Manpreet as how we should manage the waste management in an operating room. And once we have to design an operating room, what are the ideal things that we need to keep in mind? If we see the anesthesia equipment that we use, most of the anesthesia equipment, once we use it, there's one thing that comes into our minds, that is the sterility. Considering the various maneuvers ranging from putting in intravenous lines, central venous lines, or endotracheal intubations, all the maneuvers, administration of spinal or epidural anesthesia, are to be done under aseptic precautions. So once at the end of the day, our operating room is closed, we end up using an intensive amount of equipment, and this intensive amount of equipment, all of what we use has to be sterile once we are dealing with the patients. So the trend in recent years has shifted in many countries from using, there's an increase in the disposable equipment so as to prevent cross-contamination from one patient to the other patient. This was widely practiced, particularly in the COVID-19 pandemic, once we, particularly in the first two waves. Once we decide what we have to use, what equipment we should use so as to have a greener environment, a greener OT, and least effects on the environment, there are certain things that we need to understand, and the foremost is the life cycle assessment of the equipment that we use. So once we have an idea of the life cycle assessment, that is, once, for example, we are using an endotracheal tube, we need to have an analysis of the endotracheal tube right from its cradle, that is, once it's manufactured at a particular point, and up to the ultimate point. Once we are done with the case, we have finished administrating anesthesia, we have extubated the patient, and we are disposing of the endotracheal tube. So this whole step of events we take into analysis once we determine the environmental cost of a particular equipment or a particular drug. For example, if we have endotracheal tube manufactured at 2 points, one in Srinagar and one in Kerala, it's the company that's working in Srinagar is generating electrical endotracheal tubes from hydroelectricity, and one in Kerala from thermal electricity. Probably it's better to use the endotracheal tube that's favoring, that is generated from environmental friendly, that utilizes the environmental friendly electricity, keeping also into consideration the other manufacturing aspects. So keeping all these with in the United Kingdom, the National Health Services, they have made a comprehensive medical document. So once we evaluate the use of any medical device or pharmaceutical agent associated with it, we have the life cycle assessment of that particular agent. The traditional approach, as I already pointed out, was to use an equipment that is not disposable. And fortunately, if we use an undisposable equipment, most of this equipment, it has a better durability and a better quality. But in recent years, there has been a trend towards the use of reusable equipment. And once we go for a reusable equipment, many a times it increases the carbon footprints and it increases the disposable landfill that occurs in the environment. So there were some studies that were done in Yale, and it was seen that if we use disposable laryngoscopes or if we use disposable LMAs, they may be harmful for the environment. But at the same time, for example, if there was one study which tried to see the use of disposable central venous lines, and they found that if we do not reuse a central venous line, that is better than using a reusable central venous line. So we need to understand, once we have to decide about an equipment, what is of prime importance is that we have to have a better understanding of the life cycle assessment of that particular agent. Risk processed equipment is widely used in Asian countries, particularly for single-use devices. And now even environmental friendly concerns in the West, they advocate the use of reprocessed equipment. And if we follow very basic precautions in terms of cleaning, sterilization, this may provide to be a better alternative. However, once there are two papers that have come in the West, and in one paper it was published from the Seattle, the University of Washington, and the authors found that there was a huge saving of the order of around $500,000. In addition to savings, the landfill disasters, they were prevented. And again, there was a pooling of around 163 hospitals in United States, which usually they are saving around $18 million annually. But once we are using this recyclable equipment, we have to have an idea that we have to have certain regulatory governmental agencies that ensure that we have adequate performance of these equipments, they are optimal, and we have proper sterilization. In anesthesia practice, we can have anesthesia equipment in the form of pulse oximeters, blood pressure cuffs, which can be recycled. And also, if we have older anesthesia machines, they can be recycled and they can be sent to lesser intensive facilities, particularly in the veterinary areas, where they can be used judiciously. One of the most important concepts that all of us need to keep in mind once we want to make our working area, our operating rooms more greener, is as how to use the various anesthetic inhalational agents and the other anesthetic agents. Nitrous oxide and inhalational agents, both of them are harmful to the environment. And unfortunately, nitrous oxide, it's destructive for the ozone layer. All the governments across the world, they are working on alternatives for anesthetic, for substitutes for those agents that cause damage to the ozone layer. As of now, it's the medical gases that have been exempted, because around 30 to 40 years back, the amount of the damage to the atmosphere by these gases, by the anesthetic gases, was minimal. But with an increase in the number of the gases, there is now, unfortunately, a substantial amount of damage that may be done to the environment. Once we see the amount of damage that's done by the anesthetic agents, we need to keep in mind that the greenhouse gases, it's not only the amount of gas that is exhaled by the patient or by the scavenging system into the atmosphere that is important, but it is the half-life of the gas that is also important. So once we finish a case, we feel that we have used 2 liters or 3 liters of nitrous oxide for 4 or 5 years, but it's not only that volume of gas that is harmful. What is more important is that these gases, they stay for a very long period in the atmosphere and keep on causing damage to the environment and the ozone. So keeping all these things in view, the European Union and some of the Asian countries, they had a joint conference and they tried to evaluate the damage, and they developed a scale where the damage of various agents, it was graded on a period of around 100 years. And this was summed up in terms of global warming potential, where carbon dioxide was taken as the reference point. And it was seen, if we see the anesthetics, the desflurane, it has a very high global warming potential of around 2,500. So keeping these things, we need to keep in mind that once we decide about a gas, we have to take into account its global warming potential also. And accordingly, we have to judiciously plan an anesthetic regimen that causes a minimal environmental contamination. These are the global warming agents. These are the values of some of the gases. And we see from this table, the desflurane, as I already pointed out, it has a value of around 2,500. And nitrous oxide has around a value of 298, but a very long half-life of around 114 years. There was some work that was done in the last decade, and what was the authors, they tried to study, they tried to see whether we could achieve greener OTs by, they tried to compare the various inhalational agents and the IV agents. Among the inhalational agents, desflurane was found to be more harmful, and propofol, it was found to have 1/4 of the damaging potential once it was compared to the desflurane. Again, it was found various maneuvers, as was pointed out. In Canada, many centers, they have tried to use, they recycle the anesthetic gases. So they accumulate these gases and they place canisters at the end of the scavenging system and try to accumulate the waste scavenged gases out of the anesthesia machine. And then if we have a number of OTs in a complex, they assemble the gases from all these canisters, and then they try to extract the anesthesia gases and recycle them and reuse them. But what happens to the full life cycle analysis of all these retrieval systems? That is a process that is under study, and it's as of now we cannot form clear-cut conclusions whether this is helpful or harmful. Circle anesthesia system, it may be helpful in our routine clinical practice, and once we use lower gas flows, that helps to achieving a greener atmosphere in the operating rooms. So we have to use very low volumes so as to achieve a better operating room environment. And once we use this type of low volume anesthesia, minimal flow anesthesia, it's mandatory that we have to measure both the inspired and the expired oxygen vapor concentrations, oxygen and vapor concentrations. So what are the safe flows that we should use? So if we have a 70 kg man, and the minimal mandatory oxygen requirement is around 6 ml per kg. And then if we take into consideration the leaks that occur through a side stream analyzer around 200 ml, and we accommodate a leak of around 100 ml from the circuit. So it comes to around 650 to 700 ml of fresh gas flow that we are using at a particular point of time. And if we are using nitrous oxide, we have to add around 500 ml per minute. So these are some of the strategies that we need to keep in mind once we are working in an operating room so as to have a safer, greener atmosphere. The first strategy will be to minimize the fresh gas flows that we are using, keep them as minimal as possible, satisfying the minimal oxygen requirements of around 6 ml per kg and adjusting for the leaks of the side stream and the circuit loss. The second thing is there's a common practice at many places that once we are inducing the patient and once we go for the laryngoscope, we switch off the vaporizer rather than stopping the fresh gas flows. This is one of the wrong practices that we need to stop. What happens in this way is once we switch off the vaporizer, there are fresh gas, there are traces of vaporizer already in the circuit and the fresh gas flow is on. So the vaporizer inhalational anesthetics, they come into the operating room, contaminate the operating room. Once we have intubated the patient, we attach the circuit. The patient for the initial few seconds does not get the inhalational anesthetics. That is already in the atmosphere. So if we want to reduce the contamination, it's better to reduce the fresh gas flows and restart them once we have attached the circuit to that. The third thing is that once we want to achieve a particular anesthetic depth, particularly immediately after we have primed the circuit and we have set up into the maintenance phase of anesthesia, and we want to achieve the MAC values to prevent the awareness, we have to keep the concentrations of the vaporizer at a higher level than the desired concentrations. there are certain things that may be helpful in reducing the operating room contamination. If we have a neurosurgical patient, we can give a scalp block. If we have a patient who has an epidural catheter in situ, we can start with a bolus of the drug through the epidural catheter. And during these phases, we can curtail down on the anesthetic vapor concentrations. And at the same time, we should have monitors that gauge the depth of anesthesia as bispectral index or entropy that will try us to prevent the awareness of these patients. Many a times we feel that inhalational anesthetics, they are environmental pollutants, and a better alternative may be to shift to the total intravenous anesthesia so as to have a greener road. Is this true? This unfortunately is not that simple. What happens once we use intravenous anesthetic agents? These agents, they get transferred to the environment by two main routes. Either we throw off the unused drugs and they get absorbed ultimately into the groundwater, reach the water table, which ultimately reaches to the human beings, and indirectly through the human excretion, again they reach to our water table, and it ultimately reaches the human beings. We do not have enough data to comment whether these traces, they are harmful to the humans, but there is a concern about the growing children and the pregnant woman once they may reach. So how can we reduce this waste? The first, as Dr. Manpreet, I will just briefly summarize it. We have to reduce the number of these drugs that we make. We have to reduce the drugs that we routinely make many a times for resuscitation, as atropine, adrenaline at some places. A trolley like this could be replaced by a smarter, greener trolley like this, where we use very minimal syringe. And in fact, 2 to 3 syringes, we can take a 10 ml and a 5 ml syringe and recycle these two syringes, use the same syringe for fentanyl, induce the patient with fentanyl, use another syringe for propofol, a 10 ml syringe. And by the time our assistant, once we are done with propofol, we can use the previous 5 ml syringe and load it with the muscle relaxant. So this will help us to reduce the biomedical waste. In intravenous anesthetics, they have been gauged on a 9-point index. That is the PBT index, the persistence, bioaccumulation, and toxicity index. And unfortunately, most of the commonly used drugs as propofol and fentanyl, they have high PBT index. The PBT index of propofol is 9, and of fentanyl, it's around 8. So we should not load these drugs in excessive quantities, and at the end, once we have not administered it to the patients, we should not throw them off and contaminate the environment. The other thing that we keep into mind is the waste stream that comes at the end of the case. There are two types of waste that result in the operating room: the solid waste the solid waste that comes out, and many ORs in Western countries, they have developed solid waste recycling opportunities. And this is one of the waste that is sold and has a commercial value. Unfortunately, in India, we are not using it at that scale, but within the hospitals, we have started using at many places using ETO and plasma sterilization techniques where we use solid waste recycling opportunities. But more harmful is the regulatory medical waste reduction, where we have the infectious waste. Here we have lack of awareness among the healthcare workers it's only, as per the CDC, it's only 2 to 3%. That is the infectious waste, but most of us presume that it's around 50 to 70%. So we need to educate the healthcare professionals about the infectious waste and treat only the infectious waste in a regulated medical way. Once we come to the operating room design, there are certain organizations that have come to the forefront. The Leadership in Energy and Environmental Design, the LEAD, and the Green Guide for Healthcare. These two organizations have worked extensively, and they have emphasized on 6 areas of green designing in the operating room. And most of the operating rooms in India, it's not in practice, but it will be definitely in coming years. These operating rooms, they are graded on a 4-point scale, 4 categories. We have certified silver scale, gold scale, or platinum, where the LEED score is 80 or more. So what are these 6 points that we need to keep in mind once we're building an operating room? One is the features of a sustainable site. So once we're building a hospital or an operating room, we have to keep in mind that once we are developing the site, we have not played with the natural habitat. Once we have built the hospital, we have not caused pollution. We have used pollution-free methods. Once we are using transportation methods in the hospital, we are using ecologically conducive transport methods. We have provided a bicycle parking site, and we have used low emission vehicles in the hospital. And most important, the water that is being used in the hospital is harvested from a storm water design. That's, we have a topography of the whole area. We see the water table in the hospital, and we try to extract this water that comes as a result of the rain water and other natural water wastage mechanism in the geographical area. The second thing is the water conservation. Water conservation, once we use water conservation techniques by using low flow flexures, particularly in the urinals, and we use sensing devices, particularly at the sinks. And once we are recycling the water, we have to take into consideration that we are maintaining the sterility. That's also important. Then about the energy conservation in the hospital, we have to ensure that we have to try to use the ecologically favorable energy alternatives as the wind power or the solar power. In the operating room, we have to use energy saving light emitting diode bulbs. And once we are building the hospital, low impact materials that cause minimal ecological imbalance, they should be used. And we should have recycling opportunities within the hospital, within our campus. The air quality, it should be clean indoors. We should not even pollute our outdoors. Adequate plantation should be there in our hospital. It should be a no smoke zone, free of smoke from cigarettes and tobacco products. We should not use those products that cause fumes or that cause a discomfort in terms of temperature or other daylight waves. They should be also rated on an adequate scale. Creativity and innovation, this is one of the important points that has been emphasized by the LEED system. Once we are building a new hospital, creativity should be emphasized. Each hospital should try to develop some creative design that improves the ecological balance. And we should, it's better always to use an architect for the hospital who is LEED certified. These are some of the points that we need to keep in mind. Once we are having equipment that we plan to no longer to use, if it's in a good working condition, we can donate it to the veterinary labs or to the developing countries who may be in need after having a proper communication. There are a number of guidelines that have been laid down by the World Health Organization. So the recipient, they should have the maximal recipient benefit. And there should be a good communication between the recipient and the donors once we are donating this equipment. And once we are donating this equipment, we should ensure that it follows some ethical norms. For example, if we start donating syringes and we feel that the center where we are donating these syringes for, they may be reused without taking proper precautions, which may result in hepatitis or HIV. So it's better not to donate these items, which may be more harmful to the community. And the particular item that we are donating, there should be facilities for the particular area, for the recipient. They should be able to use it properly. If there is a system which does not work on electricity, it works on a specific battery, the country, the recipient, should be able to replace that battery. Otherwise, the equipment will become defunct after a certain time, and it will be again a major biomedical waste in that area. And most important of all, as we have this meeting organized by the Indian College of Anesthetists, we should organize an increased amount of green meetings, green events, so as to cause an awareness among the anesthesiologists, among the healthcare workers, and among our society, so as to create better and safer environment, not within our operating room, within our hospital and beyond. Thank you. Thanks a lot.
Thank you so much for this wonderful information. I think all the sessions were absolutely mesmerizing, with full of evidence, and there were so many key messages which we can follow in our day-to-day practice, because many of the things, whether we talk about the unused drugs, whether we talk about the volatile agent, I think we all agree that we open up a 20 ml propofol vial and we are not bothered. At the end of the day, the technician will be flushing them in some way, maybe usually in the wash basin sinks or sometime in the toilet. And there are various issues, and definitely in the operating room, or you can say a peri-operative care, we have many issues wherein we ourselves are responsible for something which we can avoid. So my heartiest congratulations and thanks to all the great speakers. Wonderful session. So Dr. Radhakrishnan, sir, your comments, sir? Or should we take up the question? There's a couple of questions which are there with us. Sir, you are muted, sir. Sir, please unmute, sir. I think by the time sir is able to unmute himself for his comments, there is one question: how to discard the expired inhalation anesthetic agents? So I think we can go to Madam Shashi, Kiran, or Dr. Zulfiqar. We talked about the liquid agents and other drugs by Dr. Manpreet Singh, but what about the anesthetic agents that are left over? I will not say left over. We have used them and then use and throw wala policy rahega. So kaise kare unka? So what options do we have, Madam?
So it's a very unique question, that how to discard the expired inhalational anesthetic agent, because in India what was happening, that in government sector a lot of things were purchased, and we were just as we were talking, that just throw in the sink. That was the practice, so as to count the bottles and say that it has been used. But it's a very difficult question, that how to discard. The main thing is that, as other speakers have talked, that it is best to talk to the companies who manufacture them and return back to them, and so that the real pharmaceutical companies and real pharmacologists, they can, I think, have a safer alternative.
Absolutely, and I think we all are very tuned of scavenging system in our OD setup, which Dr. Zulfiqar Ali also touched it. So when you talk of these expired inhalation agents which contaminates, I think this is the residual drugs that after use we have. So I think the scavenging system should be one aspect, but then it is just not, because we are releasing in the environment. So certain other techniques.
Expired,
when we talk about,
sorry to interrupt. Expired means that expiry date.
No. So, I mean, it can be both ways, madam. I think
No, leftover of each day.
So I thought it is expired, or
yeah, I think
not the expired, leftover of each day.
This was about this.
Leftover.
Yeah.
Leftover of each day. Leftover of each day.
Actually, the literature has, I have extensively searched for the literature of leftover of inhalational agents, whether it is to be used next day or not, or it has to be taken out and then we can discard it at some place. But still, it is not mentioned anywhere that how it has to be done, because, but it is very important that it will cause some harm to the environment, and it is not causing any good to the environment though. So it is not clear still that whether each day, suppose we are putting into the inhalational agent into the Tech 7 or something like that in the this vaporizer, and then after that something is used in our developing countries. It's so costly drugs, and we are not taking it out, and we are using it the next day also. So how much it has caused, it will cause harm, or how much it will not cause harm, it is still debatable. We can't say, we can just count that how much it is used, that can be possibly calculated. But whether this next day we have to remove that and then we have to not to reuse, because I have never seen our technical staffs taking those leftover inhalational agents out after the day. So rest of the other people can tell about this.
Manpreet,
yeah,
the vapors, I mean the inhalation vapors, we always tell our juniors to take it out and keep it in the original bottle, and we can reuse it. That's been followed for years together. But the question is that whether that's a correct technique. That's the only thing what we are. Is a correct. Well, I don't know whether it is a correct technique, because if there is no mention of this particular technique anywhere in the world literature also. World literature says something else. Say, as far as the intravenous agents can say propofol or thiopentone or etoposide or any of those particular things, they say, well, don't use it if it is beyond 12 hours. Once an ampule is broken, taken up before use, and if there is some 4 or 5 ml, say we have used some 12 ml of propofol and another 8 ml remaining in that 20 ml vial, but it's not proper to use it. That's what they say. But probably the developed countries, a wealthy country may be able to afford to that. Whether we can afford to that, well, I don't know. And I have not seen anywhere. And what they say is that take it in a particular container and use it for incineration. Well, throw it for incineration. This also is a safe method, I really doubt, because we don't know much. Anyway, there is very scanty literature on all these things, how to keep up all these things. Our idea, or rather what we should know about by end of the evening, is that how far or what is the practice going on in States or Canada or in UK regarding all these particular inhalation agents as well as the intravenous agents, what is left over on that particular day. Shashi, can you throw light on it?
See, the thing is that if we talk of inhalation agents, like let us talk about the specific like sevoflurane. So I am putting sevoflurane, or nurse is putting the sevoflurane into the vaporizer when it is finished. There are indicators that, okay, it's finished now, you refill. And the bottle, the bottle sevoflurane, So if some volume is left in the bottle, it is reused. It is tightly closed and it is again filled up, used for filling up next day. So that is about the expired, expired.
It's not expired, leftover.
Yeah, leftover. It's left. Expired means that expiry date.
Yeah, okay, right. Expired for the day. Yeah.
Yeah.
Leftover is, yeah.
So leftover is really not leftover. So one should be careful. The nurses should be, or the you technicians which are working with us, they should be encouraged, or they should be, made aware that fill up the vaporizer, and whatever is left over, tighten it, and it can be used to refill the vaporizer when it is empty. So
But that's a very acceptable argument. It is a safe argument, because that's what is there in the vesicle, the vaporizer. It's not going to contaminate. Right? It's not going to contaminate. It's going to remain there. That means we may be able to use it next day also. But that's not a thing. With a drawn out syringe containing 8 ml balance of the propofol, or say 4 ml of accommodated. That's what I am asking. Yeah.
Because use pre-filled syringes. That is that use pre-filled syringes, like fill up the syringe only that is required. That can be one option, like we are doing children. So only fill up 5 ml or 10 ml according to the body weight which is required.
Agree. How should I discard it? Shall I throw it? Shall I syringe out to the bucket what is with me, or syringe out into the toilet, syringe out into the wash basin? Well, I don't think this is a safe technique.
See, the leftover, unless we have pre-filled syringes, lot of pre-filled syringes according to the body weight. So that can be one thing, one option. Or otherwise, if you are filling routinely, you have to discard. Other thing is that suppose I have 2 10 ml syringes of propofol filled up, and the literature says that if one syringe is left, you can safely store it into the fridge to be used next day, not more than that.
How many days? One day more.
24
hours. Yeah.
It is basically the temperature also which is important. How much temperature, at what temperature the syringe is kept there, and then next day you can use or not.
4 degrees.
4 degrees. 2 to 4 degrees are most of the times you have to store those. But what sir is asking also is that some drugs, the people have told, manufacturers says that, and literature says that you have to discard those leftovers of the liquid that suppose 2 ml or 3 ml of neostigmine, suppose 2 ml of adrenaline. Suppose these drugs can be put into the basins, and into that they should be washed away into the pipelines, because these cannot be reused, by misuse cannot be there. So that could be discarded, and that should be audited and noted somewhere. Record keeping should be there, and what it has been discarded, how much amount is to be discarded. This is where the literature.
Yeah, Manpreet, that's a very correct technique, because that should be audited, because that's a very correct technique, because the leftover adrenal or ephedrine, okay, you throw it into the wash basin, and well, syringe out and record it somewhere. Well, I have thrown this much. Well, is that same followed for propofol or thiophanate or recombinant? Because there lies the problem.
They have told that, keeping in view that what is the environmental effect of propofol leftover washout, the thrown away. If you throw into the water or sanitation, these sinks, so that's why they have said main thing, whatever you are telling is absolutely right, because main discussion is on the propofol only, because propofol causes the wastage of the propofol causes ecological disbalance in the, but it is very at the low intensity. So that's why still it is unclear whether the amount of harm which the propofol in the environment causes is more, or what are the advantages of propofol and where we can put that. But it is definitely to be discarded within 12 hours. That is the important thing.
That's good. Thank you for clearing. Yeah.
For narcotics, I would like to highlight that for narcotics in the here in operating room, we have the plastic bins. So like the nurse enters routinely in the register. Suppose she has given me narcotic 100 mics fentanyl. So how much fentanyl did I use? I have to document. How much I am discarding, I am documenting. Same for morphine. And leftover, I'll show to one person at least, not me, that okay, I am discarding 5 milligrams of morphine. And we have the plastic container into which they are to be discarded, not anywhere else. And that plastic container, so there's a sponge inside. Once it is, absorbent capacity is exhausted, that is taken away by the pharmaceuticals for safe disposal.
Okay, pharmacological waste, drug waste could be dealt with that way. But the question is not that. Well, I have a 10 ml fentanyl vial with me. Idea is here not to give any chance for abuse of the drug.
Yeah.
I have used already 400 micrograms. That means another 6 ml or 600 microgram is lying in my 10 ml syringe. How am I going to dispose that particular 6 ml waste? I don't think it is proper to keep it for the next day because that's not recommended.
So this
No,
is
that
what
that is to be wasted in the, as I told, that leftover narcotic is to be discarded at least by showing to another person that, okay, I'm discarding, and that here we are discarding in a bin, plastic bin, which is kept over the anesthetic machine. And it has some, things which degrade it, and then it is sent to the pharmaceuticals.
And
Yeah.
that flush list which is given by DEA, that is also relevant in this point of view, because fentanyl and all opioids come into that 15 number which they have given. All those drugs, they have to be flushed in the toilets. That is the most.
Yeah.
Maybe what madam is saying is in the each and every operation theater they must have been the bins, and later on they could collectively they can discard into the flush bins. That is
Flush
another
bins.
one. Yeah.
Not flush bin,
flush bin.
not flush. They are returned to the pharmaceuticals for disposal.
Okay, but this flush list concept is also from the West also.
Yeah.
So that all the opioids, they are specifically ketamine also, and all these opioids and ketamine, these all drugs have to be put into the flush list. They are very strict about these things. But with the DEA regulations, it is a regulatory body also which takes care of these things.
I think it's better we record it somewhere and then syringe out the balance into the drain.
Yeah, it is always record keeping side by side.
Yeah.
Without that, we can't do that.
Correct. Okay.
Specifically for the expired opiates, it is when we talk about the ampules and the tablets, it has to be, there is a certain policy which has been given by Drug Controller of India. So in his presence, those drugs has to be incinerated. So that's a policy which is already available in India. So if you have expired morphine, either oral or
Rakesh,
IV,
it's not regarding the expired. It's not regarding the expired. What we are concerned about is the leftover of the day.
Somebody asked about the expired drugs also.
Expired, we know the drill. Expired, there is a standard drill worked out everywhere by the Narcotic Control Board. That particular drill is being operated throughout India because we're going to keep it to the excise department and they take it out and they destroy it. Okay, absolutely no problem. But every day, instead of making it a habit or sort of an abuse by our union staff or some of us itself, well, what we should do with the leftover? Because I know anesthetists in the past who used to use only a small quantity of the narcotic and keep it there, and silently they push it into their body. Sometimes, even to some extent, that they openly syringe out into the mouth. That means the drug as such is taken as along with something else as a drink. And these are the things which were going on. These were the abuse because these were all picked up.
In one of the literature, sir, it has also been mentioned in the toxicology literature that some people who are drug abusers, what they do is that in the operation theater they fill with some other fluid or normal saline instead of these things. So that we can't take it, but it is given in the literature also.
That's common. That's common.
Yeah,
common.
Yeah.
That's still going on. Yeah, that's still going on. Yeah.
So here we have to discard the phenylephrine bag also into the sink because of the fear that if phenylephrine bag is left outside, someone might consider it is a narcotic and inject.
Yeah.
And that's because of the,
So all these problems can have.
yeah.
Okay. Thank you all very much for the excellent talks and the
Thank you, sir.
information passover.
Sir.
Dr. Hello,
Yes, sir. Sir.
Jayashree, anyway, for a sum up, I requested Belji to give the vote of thanks. Before that, I request Jayashree to make a sum up of the event of the day, if you are available anyway.
So madam is here, sir. She is joining.
Yeah.
So by the time she's joining, we can just welcome for the next webinar, which will be on next Wednesday of on another very important topic of the simulation. Now in teaching training, whether we talk about the NMC and erstwhile MCA earlier, or whether we talk of DNB, simulation has emerged as one of the classical way of teaching. And in the perioperative period, now we have many options available for doing simulation to bring those real-time scenarios. And though in Western countries, it was the commonest thing, but it has been picked up in India. And this interesting session will be on next Wednesday, March 9th at 7 p.m. So do join. It will be moderated by Dr. Indu Sen, and we have wonderful speakers with a lot of experience in simulation. Dr. Dinkar Pai, Dr. Vibhavi Upadhyay, and Dr. Tilaka Mataya will be the expert speakers for the same. So please join next Wednesday, 7 p.m. Dr. Jayashree Sood, ma'am. I think some network problem with her, sir.
Yeah, then we'll request Dr. Beljit to say a word of thanks.
Well, good evening, everyone. There was a network issue at my end also. I missed out some of the presentations, and then I spoke to Dr. Sanish. He saved me up. He saved me for by sending a link to rejoin. So I joined 3-4 times in between since the connection was poor. So that I'm sorry for that. Anyhow, what I could hear all through the session, it was one of the most remarkable webinars that we have had. Remarkable from the side that, we do all these things daily without really knowing what harm we are causing to the environment, right? I mean, just like what Dr. Shashi told right in the first talk that was on energy and carbon footprint, how much harm is occurring to the environment. I mean, using desflurane, using sevoflurane, she gave a very clear information with regard to how much carbon footprint every anesthetic agent that we are using is doing. And I think this was quite enlightening. At least I'm quite enlightened with the talk that she has given. Excellent talk, very, very comprehensive coverage of the whole subject that was given to her. Then the safe disposal of leftover anesthetic drugs. The presentation apart, a lot of new information which was given, and thereafter the interaction which occurred after all the 3 presentations. Again, I think this was a very important thing, a very important lesson that we take back home after this discussion. And of course, the eco-friendly operating room by Dr. Zulfiqar Ali. Before that, Dr. Manpreet's talk again. And Dr. Zulfiqar Ali highlighted various issues related to the operating room made as eco-friendly. I think in case we can put into practice all these things which I'm saying, I think many other things can be done simply with just the awareness. And once we are aware that such things cause a lot of harm to the environment, I think we can do our own bit by just taking care of all these things. And if we do that, I think we'll do the Mother Earth a lot of good. And of course, to the environment in which we live and what we will be leaving for the next generation. Friends, it was a great webinar. I congratulate all the 3 speakers, Dr. Shashi Kiran, who joined from across the ocean, and Dr. Manpreet Singh, again, a very erudite speaker, and Dr. Zulfiqar Ali as well. All the three presentations were just superb, very enlightening, and I think each one of them has done a great job to the topic that was given to them. So on behalf of Indian College of Anesthesiologists, the president and the entire executive team, I congratulate the speakers first, and I compliment them for the great work they have done. And of course, to the audience which which participated, I think this is the motivating factor that we have, that since the audience is there and they are in large number, not only that they listen to the webinar proceedings, they also connect later on to sort of those who miss out on the live webinar. They connect to learn from that. And of course, I would also like to thank Clarinet for providing the platform for this webinar. And thank you so much once again. And I come to close this session out. Thank you and good night once again.
Good
Thank
night.
you and good night
Thank
to
you
all.
so much.
Thank you.
Thanks
Thank
to
you.
all, sir. Thank you so much.
Bye. Good night.
Thank you.
Good night.
Good night.
Good night
Bye.
also. We are closing here. Thank you.
Thank you so much.